Hello friends, my name is Dr. Saif and we all are aware that prone positioning is quite beneficial in improving oxygenation in ARDS patients, especially the patients who are in severe refractory ARDS not amenable to any form of treatment. So in such cases, we usually advise prone positioning. Studies consistently demonstrate that prone positioning yields an average relative improvement in PF ratio by 19 to 35%, especially in patients with moderate to severe ARDS. Across major clinical trials and meta-analysis, which are the forms of highest evidence possible, approximately 70 to 80% of ARDS patients were prone responder, means that there were improvements in oxygenation, and this is why this prone positioning is quite a popular way of improving oxygenation in such patients. Patients with lowest baseline oxygenation, for example, severe ARDS patients who have PF ratio less than 100 have consistently shown profound improvement in oxygenation up to 27 to 38% increase. Now, prone position heavily impacts hemodynamics. That's also very important. As we know, that it improves the oxygenation, but what are the impacts on hemodynamics that we are going to discuss today in this video. And first of all, as we do, we have to discuss a case scenario. So what's case scenario? Let's start with this case scenario. A 45-year-old man with severe ARDS secondary to pneumonia remains severely hypoxemic despite best mechanical ventilation settings, and his PF ratio was 85, and he is acidotic now, and TTE demonstrates that there is feature of acute cor pulmonale with severe right ventricular dilatation and paradoxical septal motion. Prone positioning is indicated and initiated to improve oxygenation and reduce right ventricular strain in this patient. So now question, there are 5 choices here. This is a type of question. To this case, we are going to discuss and we are going to understand the basic mechanisms, how patients develop hemodynamic issues when they are prone. ARDS often causes RV dysfunction. Do you know the percentage? It's huge. 20 to 50% of cases of ARDS, depending upon the severity of ARDS. RV dysfunction occurs due to widespread hypoxic pulmonary vasoconstriction and high airway pressure. There are 2 important entities which are affected by the ARDS. One is hypoxic pulmonary vasoconstriction, because these patients are hypoxic usually, and we are keeping the saturation between 88% to 92% as per protocol, and also PF ratio AO2 55 to 80. So we are little hypoxemic, permissive hypoxemia you are following. And such patients, as you know, because lungs are so stiff, so they are basically having high airway pressures on ventilator screen because of stiffness of lungs. So positive pressure mechanical ventilation, increases the alveolar pressure, and this compresses the delicate pulmonary capillaries running between the alveoli. Beautifully, you can imagine that these capillaries which are running between the alveoli are compressed by excessive intra-alveolar pressure caused by mechanical ventilation. So this is one effect. What happens here? Further spiking pulmonary artery systolic pressure, which is normally 25 millimeter of mercury, but routinely climbs to 40 to 60 millimeter of mercury, up to 50 millimeter of mercury in case of mechanically ventilated ARDS patients. And in cases of severe ARDS patient, it may reach up to 60 millimeter of mercury. So maximum is 60, they have documented in case series and case and investigations. And this puts extra pressure on RV, resulting in massive increase in the RV afterload. So now we have understood that there are 2 mechanisms: hypoxemia leading to pulmonary vasoconstriction, which increases the pulmonary artery pressure, and second reason is mechanical due to increased intra-alveolar pressure the capillaries running between alveoli are compressed, leading to spiking of pulmonary artery pressure up to 60 millimeter of mercury, starts from 40 to 60. By recruiting collapsed dorsal lung units, prone positioning improves the oxygenation and reverses some of this hypoxic vasoconstriction. So as we know that prone positioning improves the oxygenation due to gravitational advantage. So what happens? Because of improvement in oxygenation itself, some part of pulmonary vasoconstriction will be reversed, and that will improve the pulmonary artery pressure. Furthermore, it opens up compressed pulmonary capillaries directly, reducing the pulmonary vascular resistance and RV afterload. So as this statements and this slide shows that prone positioning reverses both mechanisms of increase in the pulmonary artery pressure. One, hypoxic pulmonary vasoconstriction. Two, alveolar pressure also gets low, and this is the reason the pulmonary artery pressure becomes better, and RV pressure also becomes better, and RV dysfunction becomes even improved. Now we will talk about the hemodynamic stability, means what happens to blood pressure. So as you know, hemodynamic stability depends on intra-abdominal pressure, and in prone positioning there is increase in the intra-abdominal pressure. If we are not taking care of the abdomen has to be free as per standard of pulmonary prone positioning. We need to free the abdomen, otherwise it will increase the intra-abdominal pressure. So what happens? Suppose in prone position intra-abdominal pressure increases, then that will push abdominal blood forward, briefly boosting the preload and cardiac output. So this is beneficial effect. Okay, it will increase the venous return and improvement in the cardiac output. So this is one effect. Second is, there is also reduction in cardiac output noted in hypovolemic patients, especially this is important. In hypovolemic patient, there could be reduction in the cardiac output, or if there is excessive increase in intra-abdominal pressure, that can squeeze the veins and can reduce the preload, and that might drop the cardiac output. So there are two mechanisms of dropping cardiac output. One is decreased volume status, hypovolemic patients who have already collapsed IVC, so they will develop hypotension faster with the prone positioning. And second, if the intra-abdominal pressure is very high, that will cause some obstruction, increasing the resistance of the blood flow reaching to the right heart, and that will decrease the cardiac output. So overall, IAP can have both good or bad depending on how a patient's volume status is and how bad is abdominal compliance. Okay, so both reduction and augmentation of cardiac output are possible caused by intra-abdominal pressure, and this is the reason we avoid any abdominal compression during the prone position, because there are higher chances that patient will drop the blood pressure due to increase in intra-abdominal pressure. Okay, and if suppose patient is hypovolemic, usually ARDS patients are kept in negative balance. As you know, we don't want to overload the lungs. Okay, so lungs congestion is avoided, and they say that ARDS patient we should aim for negative balance. So these patients are already little hypovolemic, and any increase in an intra-abdominal pressure will increase the events of hypotension. So now we know the mechanism. Because patients exhibit variable hemodynamic responses, meticulous monitoring is vital during prone sessions. So what will you do? You have to first continuously monitor the blood pressure. Using an arterial line, you need to do echocardiography, or at least if you could do cardiac output monitoring, stroke volume variation monitoring, which is highly recommended, that the patients will be safe during prone positioning. Okay, So this is one thing. And the second, maintain optimal preload. Preload should not be low during prone positioning, as I said, for the reasons that it can reduce the cardiac output. And dynamic test of fluid responsiveness, such as and expiratory occlusion test (EEOT), can extremely be helpful to guide the fluid resuscitation without overloading the right heart. To summarize, placing a moderate to severe ARDS patient in prone position has three principal benefits: enhancement in oxygenation, improvement in pulmonary hemodynamics, and reduction in RV dysfunction. Okay, and henceforth there is increased survival noted across various trials. So even if you see a patient which has poor RV functions caused by ARDS, PP must be advised in such patients. Let's go back to the case scenario. In this question, correct answer is B, and I'm leaving a comment box for you for your comments, and thank you for your attention. Please subscribe this channel, my channel, and like this video if you really like it, and let me know your thoughts in the comments. Thank you so much. Bye bye.